my pleasure to introduce Dr. Femke Truijens. She's an assistant professor of clinical psychology at Erasmus University Rotterdam, which makes her the person who had to travel farthest to get here. So thank you. Dr. Truijens conducts interdisciplinary research in the intersection of clinical psychology, methodology, and philosophy of science. And I was very excited to find out about her work because she uses qualitative methods to find out how patients quantify their experiences in response to mental health questionnaires and how patients interpret the items on these questionnaires. And doing this kind of empirical work is very rare. And she uses these findings moreover to challenge widespread conceptions about validity in psychotherapy research, which I think we need more of. So I was very happy when she offered to come to McGill and visit for a couple of weeks with my group. I should also mention that Dr. Truijens is also a leading qualitative researcher and the chair of the Qualitative Research Collective on mental health in the Netherlands. And if that's not enough, she's also a practicing clinical psychologist. And she provides psychotherapy for gifted adults and adolescents with mental health issues. So she knows this stuff from both the research and the practice. And today she will be speaking on what is it like to score questionnaires on mental health, utilizing qualitative methods to validate and meaningful self-report measurement. Please join me in welcoming Dr. Truijens.
Well, thanks so much for the introduction, Eran. Thanks also for having me here in McGill. It has been a fantastic experience so far. And also thanks to all the speakers so far who have paved the way to all the arguments that I'm going to give here. It is indeed going to be a bit of a challenging talk, a thought-provoking talk, because I think we definitely need that when we talk about data ethics, data use, data inference in mental health. So I don't have to introduce myself anymore. Maybe only I want to point out that I don't have anything to disclose because basically no one really likes to fund this kind of challenging research. So I'm all by myself. My lab is called the Meaningful Measurement of Mental Health Lab, the MEANS lab. So what does it mean if you are somewhere in the mean? That's the thought.
Nicely done.
Well, the lab consists of me. Basically. So now, what I'm going to talk about today, or actually what we are going to talk about in the coming hour, or half an hour, I would really like this to be an interactive thinking exercise. So please feel free to raise your voice, say whatever comes to mind at any point. I've done this talk before, but it never goes in the same way. So I really love for you to give any thoughts that you have along the way. So let's start this thing off. We are here to talk about data ethics, and we have talked a lot about questionnaires, about data collection, about getting into these data comparison levels. So when we talk about data ethics, of course, the first word is data. And what I do assume a little bit is that when you think of data, the word data, you think about basically this. Is that about correct? Recognizable, right? Yeah, something that comes to mind for almost every researcher. Maybe in different times it was also things stacked in a box, but nowadays, when we talk about data, it's very much about this. I don't know if you recognize any people in here. This is perfectly anonymized already, but this is all about people. Now, I'm going to take you a bit back in the day on the journey that I took myself to arrive where I'm at, because this is a data set from the Ghent psychotherapy study, which was the gold standard psychotherapy study that we conducted in Ghent University in Belgium. And I say gold standard, probably also rings a bell to a lot of people. So we have this very fixed and standardized methodology that we use to compare treatments to make sure that all treatments that we give are in the end evidence-based. So I was the lucky PhD student who could actually input these data into this actual data set, which is indeed the real data set. And then one day I was sitting behind my desk with my music on, really ready to put in all the data that was there at the pile, because we still used paper and pencil. And then I ran into this. Take a second to digest what you see here. This is an excerpt, a little cutout from the symptom checklist, which is beside the PHQ and the BDI, one of the most used mental health questionnaires worldwide, basically. It's a long one, and the patients that we had in the study filled out a whole, like an actual stack, a battery of questionnaires, including BDI, the symptom checklist, interpersonal, personality, all kinds of well-being questionnaires, a whole list. Now, what we look at here is, well, a challenge. Let me put it like this. What do you guys see when you look at this picture? Go ahead.
Well, it seems like there's at least one response that's kind of like, it depends.
It depends.
No.
Yes, indeed. Yeah, quite on top of the list. It's all in Dutch, of course. I realize you cannot really understand that. But it says it's not who you are, but what you arrive at that counts. And she differentiates between for me and for society. And then she draws an extra line underneath the standardized response scale, which differentiates for the two types of references, right? Okay, what else do you see?
The exclamation points.
Huh, interesting. What does it mean?
Well, I would assume it means like, oh my God, absolutely, definitely, extra, yes, this one, mostly this one.
Yes, indeed. So it gives some sort of a ranking or priority of items for her, right? Yeah. What else do you see? Yeah.
The measurement process is relational, I think.
Sorry?
That the measurement
Yeah.
process is relational.
Uh-huh.
The respondent and then the person asking the question.
Very, very interesting. What you very clearly see here is actually that she is indeed talking to someone. She wants to bring across not just some scores, she wants to bring across her experiences. And she feels that this is not enough, these lines here, these response skills. She wants to do something extra with it. Good, well, lucky for her that she could do this in paper and pencil, right? Otherwise, this would not have been possible. Keep that in mind. What else do you see?
The 3, 4, that's kind of in between.
Yeah.
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 So kind of indeterminacy of the response or
Exactly.
equivocation.
Interesting. Who recognized this from ever having been worked with questionnaires? People want to score between the numbers. A lot of nodding. This is one of the most heard things, I think, when you have this scoring system. I don't know, somewhere between 3 and 4, 3.5, something like that. Okay, and now we have the instructions, score the highest, or if you don't know, just go with your gut, just choose one, whatever. What this thingy here did, by the way, this is not the only time that she did this. So I have about 50 questionnaires of her, 50 measurement moments, because it was longitudinal, and she did it in every single questionnaire. So it also took her like 1 million years to fill these things out. But it was also adamant for her to bring across her experience, because she didn't feel a fit in these questionnaires. Okay, well, that being said, we have seen now already quite a number of important things about how people try to communicate using these questionnaires. It's definitely not a neutral thing for her. It's something that really, for her, has to capture her story. But it does something other than that. Because think back of this. Now it becomes interesting. I had to input this in SPSS. So help me out. What should I do? What would you do? Take the 3 to 4, for example. What would you decide on that? Scoring between the numbers.
The pencil is a little thicker around the 3.
Now, this is very well noticed because this is actually a system that she developed herself. She actually, at some point, she wrote a little legenda under her questionnaires and said, like, the thick lines are more important than the small lines or the thin lines. The exclamation points have the same function, right? So they signal a certain importance. She also had questionnaires where she completely collapsed, reversed the response options. So she said, it doesn't go up for me, it goes down. So I have to score the other way around. So I score a 2, but it actually means the opposite. Right? So there was this like from 0 to 5 was like, does it go better, better, better? And then she said, no, 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 it goes worse, worse, worse.
Oh, wow.
So she scored a 3 or a 4, but it was actually the complete opposite. I have a ton of pictures that I could have shown, but for the exercise, we just used this. So scoring between 3 and 4, you would say I would go for the 3 because it has a bigger line. Who's with Iran? All right, who has another opinion?
I will look at other surveys done by other people and look like there's some kind of pattern, and then whatever the pattern that seems to emerge, I would just do that systematically across all the surveys that I would be coding.
Yeah, that's actually interesting because that's basically formulating a rule on how to handle every sort of discrepancy or irregularity in scoring over a data set, right? That's basically how we work with missing data, for example. So if data are missing, we formulate this sort of statistical or methodological rule on how to handle these data, right? So we could do that, yeah. Any other options?
Just throw the whole thing out.
Thank you. I was waiting for that answer. We all laugh about this, but this is what happens, right? In practice. This is too complex. We don't do this. Come on. So what we call this person is an error, right? Whatever, outlier, out of the window. We are laughing, but inside I'm crying now. Because this is not really funny, I would say. This person takes quite an effort to tell me how she feels. And as just this regular researcher, I would probably now be inclined to say, I'm just not gonna do this. Either I make the decision for you, which is quite hard in her case, or I just throw the whole thing out. Data ethics, what are we thinking now? So
employ qualitative methods.
yeah,
In the material.
that would be fun. We might do that today. Yes. What this shows to me, or what it showed to me at the beginning of my career as an early PhD student, was there's a whole lot going on when we measure that we don't really see, because we basically force people to score on these response scales, and we simply assume that everyone does it in roughly the same way. Now, normally we rely on these validated measures where we say like they have been validated, so we sort of assume that the developers did some techniques with some like cognitive interviewing, maybe check out like, do people understand the items in the same way? And if we're good to go, we report it. There must be some paper and anywhere that we all cite where it says like psychometric characteristics of this questionnaire are fantastic, out of the roof. No one ever thinks about this anymore, right? But this is a problem, not just because it was very hard for her apparently to score this, but also because it might be important for her to bring this extra information across, but who knows what else other people are not scoring when they score? Who knows whether other people are not also having these considerations, but just do not take the effort to write it down, or do not get the room to write it down, because when we assess them digitally, they can't, right? Another very important point, bringing us back to the objectivity question of measurement, which is of course one of the most dominant argumentations for using it at all, is that I had to make the decisions here. She found it hard to make the decisions to choose between scores that didn't mean enough for her. So I had to decide, because I did this talk a few weeks ago with the methodologist group, and they were like, they went above and beyond to come up with all these procedures, a bit like you say, like having these rules on how to work with this, and we're going to like always go for the highest, or like we just split it up, or we do this entire like sample-based analysis, and then we come up with something in the middle, blah, blah, blah. I was like, it still doesn't really solve that I have to make the decisions here, right? So that's a bit of a problem. Now, I think in general, PhD students at this point would indeed think like, let's get this aside. I didn't, because I'm a bit of a atypical PhD student. So I thought this is gonna be the whole yeast of my PhD. And the question that I started to ask was, within this data set that we have collected in the GAM psychotherapy study, How do people actually produce these data that we rely on so much? And to do that, I singled out a number of cases, which, well, brought me here because around them, you read the papers and you liked it. And I'm going to talk about one case today I'm always bad in time management, but I'm going to tell you a bit about John to continue this thinking exercise. The case study, I wrote it years ago, but it was just published in Methods in Psychology. And like I said, John was a case in that sample for the psychotherapy study in which we basically looked into comparing cognitive behavioral therapy with psychodynamic treatment for depressed adults. And we did, of course, the standard questionnaire battery, but we also put in a whole lot of qualitative data collection by doing, what was it? I think 8 interviews per participant. So before, during, and then 5 times after the treatment. And which was a bit of a luxury in the ethics realm of Belgium that allowed us to audio record all the therapy sessions, which is a fantastic wealth of information, I can tell you. And then, of course, we have also a whole lot of anecdotal information like interactions, communications, emails, telephone calls, etc., that we reported in our logbooks. I used all of that qualitative data to analyze this case, which was John, which is, of course, a pseudonym, 47-year-old male at the start of the treatment. He came in with depression and burnout symptoms and severe anxiety attacks. And I singled him out, or I selected him for this study purposefully, which means that I knew already a lot about what was going on with him. He struck the eye, and I decided to study him because I assumed there would be much to learn from this case. And I'll tell you why now. So, what you have to know about psychotherapy research is like the gold standard I already mentioned is very strict. So if you want to publish, you have to follow every single step, otherwise you're just like out. So this was a protocoled study where we did, first of all, a small telephone screening. All the researchers did that in the same way, so we had the guideline. And we, of course, we gave this huge ethical committee written formatted document with all the information for participants to know, which of course we all know that they never read it, right? Well, that happens indeed. I asked him, did you read it? Yeah, I read it. Do you have any questions? No, I don't. We know that, so we also go over it orally. We explain it a bit. Okay, it was all fine. So he gave consent, then he came in for the intake interview. He did his entire battery of questionnaires. Based on the whole intake procedure, he was found eligible. Great. So we were able to randomize him. And then before he could start with that, before we could randomize him, we asked for informed consent again, because we, like was probably already clear from the questions before, I find it very important as well to know like whoever like falls out of research because they're not eligible or they drop out, or when they realize what the conditions are, they decide not to do it, all kinds of reasons. And this process allowed us to then use the intake information and compare it to the people that had this intent to treat or came in the intent to treat sample. So that being said, we gave him again a patient information talk and asked him for informed consent, and then it happened. Then all of a sudden, John realized that all the effort that he had put into the research until that moment, so all the questionnaires and the intake information, the whole diagnostic interview, was just for research. And because of our gold standard, where of course the causal conclusions are very important, we said we're not going to interfere with the regular procedures of treatment. So all this data is for research. People are also paid for the research, and then they do treatment. And after treatment, we come back here, we talk about what happens, and we assess you again. He did not get that. So he thought that all these questionnaires would be used in treatment, which I think most of you would agree to is a good idea. Well, we didn't, because that didn't fit with the RCT standards, right? John was upset about it, not to say pissed, angry, out of his mind. He was really raging. And I was sitting there like, what is going to happen here? Interestingly, this was also a very principled guy who said like, I'm so angry and you used me so much, but I'm also a man of my word. And I promised to do this, so I'll go on with it. So he started treatment being upset. And that became very interesting because he was upset with the researchers, not necessarily with the therapist. So what John did was he went through treatment to prove his point that he was a man of his word. So he said he would start treatment, so he would do it and he would end it. And it was interesting because it was quite opposite to his normal behavior, because otherwise he was very suspicious of treatment. He found people not easily like competent. So his track record showed like at least 20 therapies that he started and walked out after 2 or 3 sessions. This treatment he finished because he had to prove a point. That's part 1 of the story. Part 2 is that proving a point was part of his anger to researchers, because of course it was our fault that we didn't inform him well. So what he did to come back at us was he sabotaged his data. Interesting. So he skipped questionnaires altogether, or he said, I'm just going to randomly fill something out. Did they notice? He asked his therapist, did they notice? Or he did the questionnaires at different moments in time. We asked everyone to fill it out before treatment because otherwise the treatment might have an effect on the scoring, etc. So he quite deliberately said, yeah, I thought to just fill them out after treatment. That's fine, right? And then he asked the therapist, knowing that, of course, the therapist might get that back to us as information. So there was this very interesting engagement with the questionnaires, with the data collection. And of course, that completely interfered with every kind of information that we normally think that we would take from these questionnaires. Now, this is the whole story, but it's also backed up by evidence. So I did a full qualitative study on the expectations and experiences of John in the research procedure. And to give you a bit of an insight in some of the points that he made. So he expected actually that the university could provide better care than all these charlatans that he had met before in his life. He expected to be monitored very thoroughly, and he trusted that the questionnaires could actually help him give some sort of content to the treatment that he couldn't figure out on himself. And that's interesting also with respect around to your autonomy point, that sometimes people find it very hard to know what they're talking about or have to be talking about, because they come in a context where they expect there's a professional here, I have to say things, I have to do things, and the therapist has to help me to get somewhere, and I just don't know. He had that. So he trusted that the questionnaires would help him, but then the questionnaires weren't used. So that made John intensely angry. He said they will have the reasons that make sense for them, but he also said it's purely for them and not for me. So it made him feel used. It made him feel objectified, which basically is true, right? So, John, what are we going to do with John after this whole story? What would you do knowing this about the data collection? What would we do with questionnaires that are partly missing, not enough to say there's really no useful data, but we know so much what's going on while collecting this data? What would you do?
I don't really have an answer, but I feel like the impulse to just discard would be not only maybe ethically wrong, but in terms of drawing conclusions from the study, then you get the pro-social bias of people who completed the study are a certain kind of people, so you're not even getting a representative sample.
A lot of interesting answers in your answer. So first of all, we might be inclined to say, ditch the dude, right? Because there's so much irregularity here, we maybe cannot keep him here, because there's also a whole lot of threats to the validity of these data, right? Brings me to the other very important point that you make. Normally, we take these data as sort of this neutral registration of what happened during treatment on this one outcome scale, and we say, because we have this strict methodology in which we compare just a different treatment and other things are all kept constant, that allows us to say that it was the treatment that helped this person. Can we do that for this person? quite hard. Why? Because we don't have the proper data for it, because he jeopardized a whole lot, but also because like he did in the end follow treatment and he was surprised by himself that it actually helped. So I didn't even mention that, but this, he was like, he felt a lot better after treatment. And he was like, I still hate the researchers, but I do have to admit that the treatment was actually better than I thought. Interesting. But we can question whether that was actually like a treatment effect or that it was really heavily like interfered by this whole anger at the study procedure, right? All raises a lot of validity questions for this person. So I get different answers to the question, what should we do with John? And it depends on whether you are with psychologists who are very outspoken or philosophers who have no idea. It all depends. And methodologists who say, we just run this whole pattern-based whatever, and then we will just know. I like this group as well, because you're confused, but also not too much. So yeah,
I feel like it's also a bit like dating, like sometimes it's just not a good match given the question that you ask
Yeah.
and the kind of participant that you recruit. So
Yeah.
I think sometimes
Yeah.
it does very feel like as a participant we're like the objects, but maybe it's just not a good fit, and maybe another study could be a better fit as making them feel that they're benefiting from being part of the research. And unfortunately, he does not feel like this.
Well, it's
given the
also,
certain
it's an
question.
interesting thought, because like if you go by John saying that like normally he wouldn't even give treatment a chance, then chances are quite high that normally if he wouldn't have been so upset, he would indeed have disappeared after 3 sessions, because he always did, right? Which is interesting, because that would have given us quite some information on dropouts. In that line of thinking, maybe he gives quite interesting information about dropout, because what prevented him from dropout was the fact that he was so angry and really wanted to prove a point. So there was meaning to the treatment that was not about treatment, but about something else. So this could raise some sort of a new hypothesis, maybe.
So a quick clarification question. So, I mean, generally we assume people fill out questionnaires truthfully.
Yeah.
And are not sabotaging. And so in this case, you happen to know that there was someone that was sabotaging. So if you had participant B who also had incomplete questionnaires, what would you have done?
That's a fantastic question. What would we have done? Well, nothing, because we wouldn't have known, right?
Well, it's just because you know.
This is because we know. So it puts me in a very awkward position where I have to decide, like, do we leave him in? Do we not? Like, I was this weird PhD student, like looking into this, but normally this doesn't happen. It would maybe be noted in the logbook, but that's about it. Then people just go in the sample, assuming that there's enough data to not get into trouble with the missing data amounts. But then they would just disappear in the sample. They would just be in there. And in this case, that would happen, but especially in the case where you don't know about any sabotage, it just gets in the sample. So we don't know, basically. And that's part of the problem, I would say. Another part of the problem is that the missing data that we talk about here is quite informational data. It's not missing at random. It's not because of sloppiness or misunderstanding or whatever, making mistakes. It is very informative, purposive, meaningful missing data. So ditching him would be, I would say, a very unethical thing to do. Just like we saw before with the person scoring a lot to tell us the proper story, in a way, John also tells us the proper story. It's actually quite nice of him to show us all this information. Nonetheless, it is a huge threat to validity of data. And what we don't know is whether this type of threats to validity of data, which of course quite jeopardize the validity of all the inferences that we will make afterwards, we don't know how often this happens. We simply just assume that people fill out our questionnaires well because this questionnaire is validated and we all use it. And there are all these psychometric papers saying it's good to go, but we don't know. And then finally, there's a whole lot of meaningful information in this case that might indeed raise some sort of new clinical thinking. There is a sort of an element of surprise in here, which we might argue is actually the whole point of doing scientific research at all. You want to learn something new. And that was also already mentioned by several speakers, I think a bit between the lines, is that we do want standardization, but we also in a way limit being surprised by something new, by new values, by new experiences that we didn't think about before. This is exactly the type of information that might help us to get a new direction, to get a new idea about dropouts or about anger or about whatever kind of personality style in treatment, right? So I would say, don't ditch this guy. I didn't, I did a case study, but normally it would happen. So the conclusions that I derived with this case, which of course I use, like it's just one case, but I use it as an illustration of a whole lot of things that we don't know when we collect data. The point that I would like to make with this case is that scoring self-report measures is an active act of meaning making. People are not just neutrally registering, sort of self-observing what is going on. They're not robots. They try to interpret the questions. They have to translate their own experiences into these numbers. Numbers are meaningful to them more than just, I am 4 out of 5 depressed, right? Secondly, overlooking these meaning-making processes may invalidate data. I say may because it's not necessary that it happens. The big problem though is that we don't know because we never look into it. We don't know whether there are invalidation processes going on there due to the meaning making. And finally, and that's especially for psychologists, a very important point, a validity of a measure as such is not enough to get this out of the root. It's not enough to cover any kind of invalidation when you do actual data collection. That makes a very important point. Then we get a bit to the responsible measurement section. It is the responsible of the administrator of a measure in whatever local context that you use it to make sure that the data is valid. And then we arrive at the hardest part, because the numbers themselves might not really show you whether there were invalidity or validity issues going on. So we need something else. And that's why, well, I use qualitative research here on case level. I also realized this is a very nice talk and thought-provoking, but now we have to do something extra. So I'm now working on studies to basically explore how we can, in a more systematic way, utilize qualitative mixed method validation or mixed method measurement. And there are several ways to do that. Of course, we can all think about the sort of the essay boxes that you can incorporate in questionnaires, open-ended questions, maybe some sort of a ranking scheme where like the exclamation points, like June, the first case showed, can actually do that, right? So make a sort of a ranking. Personalized measurement is a whole new thing, which is very interesting because you ask people basically for their meaning and then you continuously assess it. But we can also think of more like proper qualitative methods. And that's what I'm working on at the moment in my meaningful measurement lab that I already introduced. I'm working on this study with the title that you may recognize from the talk, I feel 4 out of 5 depressed. And what I do in that study is we compare thinking aloud methods, which means that we ask people when they score to do that while verbalizing all their thoughts, so thinking aloud. And we compare that with after the scoring, going back to the questionnaire and telling us all about like what happens for you to get to the score. Did you get into any irregularities? Did you get into any problems? Of course, I don't formulate it as problems because that would be priming. So we just ask them for the meaning making. We're still in the middle of analyses. I hope next week in Calgary, like we are at 75% of analyses, and maybe we're gonna get there next week. Do I have like 2 minutes to tell you anything about it?
You have 5 more minutes if you want to leave only 5 minutes for open discussion. So we have 10 more minutes for discussion. But you asked me to go longer, and I'm perfectly happy with that. So it's up to you.
I'm just gonna ask the rest of the group, like, you want to look into this quickly, or you want to have a discussion? This quick. So first of all, what is not surprising is that we see a whole lot of issues that I already raised here. So scoring between numbers, having a hard time with instructions. Some people, so we use the back depression inventory for this, which is of course the most hallelujah validated questionnaire that we have. Well, validity issues are like omnipresent in the scoring. And it's both for people without and with depression. So we have a full group of people. So we see a lot of in-between scoring. The BDI is of course notorious for using like written labels with the numbers, which makes it like not a proper quantitative scale at all. People say like these labels just don't fit my experiences. The gap between 0 and 1 is like huge. I don't know what to choose. And there's a lot of confusion over the concepts that they have to score. But then what I think is for me the most interesting information that we gathered so far is that people are very aware of what the BDI is supposed to assess. So they know it's a depression measure. And they say all the time, yeah, I think I should have to score this, but yeah, that would sound really depressive. I don't think that's the case. So no, I'm going a bit lower than that. Which is interesting meaning, right? Because that's not like a neutral assessment of yourself. It's an assessment through the discourse of the administrator. Another very interesting finding so far is that in quite a few participants, we see that certain behaviors that we associate with depression are interpreted completely the other way around. So here you see the crying quote. Someone saying, yeah, I cry more, but I think crying is good. I think it's a positive thing when you do it in healthy doses. Others have said, I was so depressed that I wasn't able to cry anymore. And now I finally can cry, so I cry a whole lot more than I used to. But that's such a good thing. I'm so happy about it. So what do they have to score? So it's very hard to really get that quantified in the same way for everyone. And then what we assessed so far is the added value of thinking aloud while scoring. And one of the things that I would really like to share with you also when you are looking into a clinical context of using data is that they say that thinking aloud really slows people down because they have to read out the question and the answers and then verbalize their thoughts. And they say, that's the most interesting, they say, I used to sort of avoid reading this. I just skim through it, score, whatever, done. People with anxiety might find questionnaires very frightening because they're basically like scary stimuli, right? They confront people. Depression the same. If you are really suicidal and you see an item on suicidality, you might find yourself being like confronted with how high this is, right? So people tend to skim over these questionnaires. And they say with thinking aloud, what we see is that it really slows us down. And it is confrontational, but it also makes me realize that this is like, I do score much more honestly in this way than normal. So yeah, this is not really a very structured presentation on the, the current findings. I hope to be able to do that next week. But I think it's a very interesting, way of using qualitative methods as basically generating validity evidence, but also probably as a way to understand the whole meaning making around questionnaire scoring better for people in clinical practice, which might be beneficial for research, but definitely also when you measure in clinical practice, where this whole one-on-one generating information to know what to do next, there the information is actually, the meaning making is the most important point. So I'll keep it at that. Thank you. I'm curious.
Maybe a bit more than 5 minutes for questions because we started a little late. Yes, floor is open. This is already a participatory workshop-y style presentation, which I really appreciate. Yes, Darius.
I was only 50% up, so my question is 50% formulated.
That's fantastic. I love those things.
Yeah, do you think with a lot of this information, would it still be a goal at the end of the day, or would it even be possible to quantify it, or are there certain things that we can't quantify, and how do we incorporate that into our kind of like scientific model?
Yeah, that's the question that bugs me also at night. Around, I have been talking about this a lot also. I'm really in the Leah McClymon's camp. I'm looking at this from a hermeneutic perspective. So what I normally claim based on these kinds of discussions is that numbers are actually words in a clinical story. So if you take them as sort of meaning holding units, they are very meaningful for a person within a story, within a context. And that's where the individual level is so interesting, right? So if you do like patient-informed feedback, like if you have a questionnaire, you discuss as a therapist with your patient, okay, you scored this, what does it mean for you? What do you think, etc. I gave the example to Aran of people that know that they're super suicidal, but they also are so institutionalized that they know that when they score a 4, all flags and all alarm bells go off and they're like, I just don't want to bother, so I score a 0. As a clinician, I know my patient. I do sense there's something off there. So I'll inquire about that 0. What's this 0? Tell me. So it's more meaningful than just that number. So on individual level, I think you can use numbers very well to sort of get in like aligned in the story of the person, help the person to also figure out themselves where they are at and get into this diet. From there, I'm really confused. So no answers from me, but that's like what we will be talking about further, I think, and I hope with more people here in the room eventually, that from this individual level, you have to aggregate. And from the moment that you first aggregate to institution level or to national level, something happens with that data that I just don't understand. And I think we have to look into that exact step from individual to aggregation, because that's where we make it into a nomothetic thing or something that allows for nomothetic understanding. And I don't know how it works. I just don't understand it. So I hope that we will figure it out at some point.
I have a question. So this is kind of continuing an ongoing conversation, but you mentioned the word validity several times in your talk, and I assume that what you meant by that is just more or less what measurement, what health outcomes researchers think of as validity. And I mean, one way to interpret your talk is to just say, throw validity away because it's the only validity you're going to get out of people's experiences, and those are idiosyncratic. But is there hope for some other conception of validity that is consistent with the vision you have, and if so, what would that validity look like?
This is even further back in my career. So my master's thesis was on the validity issue in in psychotherapy research. I used to be skeptical about it because indeed, if you like ask students or like researchers, like what is validity, they say validity is if you measure what you want to measure, right? So when the measure is capable of like grasping or covering the constructs of interest. I think this shows that's a bit shaky. What I do think is that if you take validity as more legitimacy of your inferences, that it is a very influential way of thinking about how you go from data construction to data collection to data aggregation and then to your inferences, and you have to be aware of all those steps. And then if your inferences are legitimate based on the data that you got in the beginning, I think we can talk about validity, but it does ask for a completely different understanding of validity in a more qualitative way.
If I'm quick follow-up, then what is it really a dramatic shift? Because haven't Samuel Messick and Michael Caine already talked at length decades ago about like the argument-based approach to validity, validity being a property of inferences. It does feel like what you're doing is more subversive than that, but so
it's not, because I really love the term validity in action by Pamela Moss, who is indeed in the Caine camp, so the argument-based validity understanding. What I love about her term is that she says it's not so much about like a measure holding a type of validity, it's about what the user attempts to do with these data within the local context based on whatever was put in by people themselves. And that's a whole coherent, or well, not coherent, it's a collective of information basically, and you have to make sure the inferences match that situation. I love validity in action because it puts the responsibility of validating on the user. So I'm all for that.
Good. Okay.
Yes.
Yes.
Yes, I have a quick question. So with John as an example, we kind of see him as an outlier.
Uh-huh.
And sometimes I find like with let's say a qualitative approach, I think one question I would have is how generalizable is this information that I'm getting from this person to other people, because people probably would wonder like if I'm using this information to apply some kind of more like population-wide intervention, then I want to be sure that this information I'm getting from this particular person is applicable to a significant amount of people for
It's a great
my information to be meaningful.
It's a great question and an important one, because generalizability, we tend to interpret that in probability statistics type of understanding. So we assume that if we collect a random representative sample, then we can indeed sort of transpose this knowledge from this sample to a larger population, right? If you use qualitative terminology, we don't talk about generalizability because it preassumes or presupposes that people in that sample are indeed representative for others outside, in other contexts, other local situations, circumstances, etc. I do not really assume that. I think that when you have people in like the Netherlands in a psychosis facility, that's a totally different context, different discourse, different understanding than people that have psychosis in an institution in America with a different type of access to healthcare, etc., etc. I think that all influences. So in qualitative research, you wouldn't say you wouldn't assume generalizability necessarily, but you do look into like the transposability of the information. So say this was studied in the Netherlands in that local context. I am here in America in this local context. How much of an overlap is there? Can I use this information for this particular case? That's interesting because it's a bottom up, right? So you start from the situation and then you assess basically, is this generalizable to my situation, without the assumption that it will be generalized to everyone. That's bottom up, and also it gives the responsibility to that local user. So it's still a flipped way of thinking.
I see, thank you.
We're gonna get into your time for your talk, so maybe save that for a little later. And let's thank Dr. Truijens again.